Hello, Declan.
Hello, Renu.
This is amazing. We're finally at the APCCC in Lugano.
Would you look at this place?
It almost doesn't look real to me. It almost looks like it's painted.
Lake Lugano. It's just that shimmery, still lake with these soaring mountains all around us. Just beautiful.
Snow-capped mountains in the distance. I mean, Switzerland is incredible.
So if you're going to have a prostate cancer congress, I can't think of anywhere better than by the shores of Lake Lugano here in Switzerland.
Yeah, definitely draws a crowd.
It is. So we're here for the APCCC, the Advanced Prostate Cancer Consensus Conference, which is a very special meeting, only takes place every couple of years. Many of you have probably heard about it already. There are always very famous papers that come out of it, and you'll often see people at meetings showing the results of what the panel voted on at the APCCC. How should we manage this patient with disease only seen on a PET scan, blah, blah, blah. Really contentious topics. And it's set here in the background of a conference where they've got 70 or 80 invited panelists, the real creme de la creme of experts in prostate cancer, delivering state-of-the-art lectures, and already have voted on these questions. So
and
it's a unique format, isn't it?
It's been a very, very small meeting, but I think for the first time in many years, over 1,000 registrants here.
It's huge.
Huge. The audience is packing the centre, and the great thing about it is it really asks some complex questions in prostate cancer management, and the panel aims to get to a consensus at the end, and it really guides practice.
And it's usually very robust. There's some really great discussions. These people here have led some of the best trials in prostate cancer, running the best trials, so there are really pointy topics, and there's plenty of banter and back and forth. Very multidisciplinary.
2 or 3 very intense days of science and data and collaboration, so it's a fantastic meeting.
And we're going to try and bring you a flavour of it. Thanks very much to our gold partners, Bayer China, who also support these podcasts, bringing you conference highlights. So we will catch up with hopefully some of our Chinese delegates here as well.
Absolutely. In fact, everywhere you turn, there's someone you want to interview, so we better get to it.
Get to it. We'll bring you a few highlights. Enjoy.
On the first evening of the APCCC, we attended a reception down by the shores of Lake Lugano as the panellists gathered from around the world. And as has become a tradition, Professor Joe O'Sullivan, oncologist from Belfast, and his son Ushin entertained us with some music.
Better start screaming or you'll sink like a stone, for the times they are changing.
So it's the welcome reception on the first day of APCCC here in beautiful Lugano. And we're here
Lugano.
with our host, Silke Gillessen, along with your co-host, Aurelius Omlin. Thanks very much for having us all back, Silke.
Yeah, thank you very much to come. I mean, you flew really a wide way to come here. So thank you very much. And I just realized we have a lot of Australians here this year.
There are.
So it's quite nice. So we really realized that PSMA therapy is coming, and the Australians are at the forefront. What can we do? So we have a lot of Australians here, and I'm really happy about that.
They've come in force.
Yeah,
Yes.
and it's exciting. It's the eve of the meeting. We're here just outside the reception. It's been really nice meeting all these prostate cancer experts from around the world. But Renu, it is exciting. You feel we're on the edge of a meeting that's going to deliver a lot of really cutting-edge updates in prostate cancer, don't we?
Yeah, so I mean, you're really tackling the really difficult questions in prostate cancer, and that's a tough thing to do.
Yeah, and to be honest, I mean, we saw now the results, right? We have chosen of these 183 questions, some questions, and the votings to discuss in the next 2.5 days with the experts, because really the results some of them are really astonishing. I'm not going to say anything. I'm not going to do a spoiler now, but it's quite interesting. You know, there's some things that I would have expected, and there's some things that I wouldn't have expected at all. And I think, again, the gaps are quite obvious. So where we couldn't find consensus in sometimes really important questions that are maybe not so sexy, like how are we treating hot flashes?
Absolutely.
It's quite interesting, what comes out. So I'm really, really excited to hear what Anthony Joshua is saying about it. So yeah, I'm really happy and I'm really excited to see the conference.
But not to take anything away from today, because today was translational day,
right?
And it was a fantastic day.
Thank you.
Had
very
some
much,
big
Renu.
names up on
Yes.
stage. What were your highlights?
So I have to say my highlights, I mean, I work with Andrea Olimonti, so I'm very biased, and I think he's a genius. So, I mean, he has always really great ideas, and we are working quite closely together, and that's really stimulating. Johan de Bono's talk, I think, was fantastic. So, the idea really of that day was that, okay, yes, on Thursday, Friday, Saturday, we really tackle really clinical questions. But maybe on that Wednesday we can find new ideas to bring the researchers closer to the clinicians. So I think it worked quite well. So I heard already a lot of corporations that started, but was super nice because that's exactly what we want, right?
Bridge that gap between clinician and scientist.
Exactly.
And, I mean, this is the future of prostate cancer.
Exactly.
And that's it. The main clinical sessions kick off tomorrow. And as Silke was hinting, the panel questions and voting are the backbone of this meeting. 183 odd questions that we've had to vote on, and we'll be bringing you a flavour of those questions over the next few days. I have to say, my session tomorrow morning, where we're voting about PET imaging, DRE, I was shocked at some of the voting. So maybe we'll talk about that in the next few days.
Yeah, we will.
So we're excited. So look forward to a great few days here in Lugano, Silke.
Thank you very much, and thanks again for coming. I mean, it's really great that you're here, and you really always kind of find the way to also kind of transfer the ambience that is also important, right? It's not only it's very much about the practical things, but then it's also about the discussions and, what do the others, and I think it's quite interesting.
It does help that it's set in beautiful Lugano with the mountains and the lake and the sea and the sky. It's amazing.
Great. Okay. Great few days ahead.
Yes.
Get on the new one, you can't lend a hand, but the times they are changing.
So it's day one at the APCCC 2024. We're in Lugano, and I'm here with Derya Tilki, urologist from the Martini Clinic. Derya, how's the meeting going so far?
It's great. It's amazing. We already had the first two sessions this morning.
Yeah, it was very intense sessions to start things off, and it would be the case because it's 2 days, so it's very much to the point. And we started off with high-risk prostate cancer, and you featured, as chair of the panel, as speaker, and your papers are always quoted almost in every talk. The highlights for you from the session this morning?
From the first one, you mean?
Yeah.
So there was an intense discussion as always, on the performance of lymphadenectomy. It's always the same discussions, and especially with the change in recommendation in the EAU guidelines this year, it's a hot topic. Also with the unclear data presented by Karim Tougir at EAU, with the longer follow-up from their lymphadenectomy trial. So it remains a lively discussion.
Absolutely.
That was the main thing from that.
Thrust back into the limelight, I think, with the recent change in EAU guidelines and the presentation at EAU by Tougir's group. Yeah. And you yourself gave a fantastic presentation this morning on PSA persistence versus recurrence after surgery. That's an interesting topic. These patients are different, aren't they?
Yeah, thank you. Yes, they are very different. So it's totally clear that persistent PSA patients do much worse. There's only a minority of these patients who don't progress, but in general, they really have worse metastasis-free survival, worse overall survival. So these patients have to be watched closely.
Yeah.
Definition of a persistent PSA is a PSA above 0.1 within 4 to 8 weeks, so they never have undetectable PSA. And these patients clearly are at risk. The EAU guidelines recommend performing a PSMA PET-CT in these patients and do salvage radiotherapy plus ADT.
And what is your trigger for treatment in PSA persistence? Is it, do you always do a PSMA PET, or is there a PSA trigger for commencing treatment?
So we always, as in biochemical recurrence, also in persistent PSA, we always do a PSMA PET-CT. We have it available. Also, clearly, we look at the other factors such as Gleason score in the prostatectomy specimen, preoperative PSA level, to see how the risk is, and if it's all adverse pathology and a high PSA and persistent PSA after surgery, then we don't want to delay treatment.
All right, and we're really only at the start. What are you looking forward to? What are some of your highlights going to be for the rest of the meeting?
Yeah, we still, that second session hasn't ended. We still will talk about biochemical recurrence and see the answers for the questions.
Fantastic.
But I'm also looking forward to the debates in the hormone-sensitive metastatic setting and the castration-resistant setting, where we have a lot of new data in the last 2 years. And the most exciting is always the answers of the panel to the questions.
And that's the thing, isn't it? When you have such controversial topics, answers are sometimes hard to reach. So those answers that the panel gives us are going to be the really most important take-home points.
Totally.
Well, Derya, wonderful to have you on the podcast, and enjoy the rest of your meeting.
Thank you very much. You too.
Okay, so Declan, day one continues, and in fact, you're one of the main stars. You had the ultra-glamorous topic of the role of DRE in high-risk prostate cancer.
Yeah.
How did you land that role?
Well, yeah, so DRE, or digital rectal exam, is the old-fashioned prostate exam that us urologists like to do. It doesn't get a lot of glory, does it, at big urology meetings, but Silke and Aurelius, so there goes the cowbell.
There's the cowbell.
We have to do a talk about the cowbell. So Silke and Aurelius put it at the very top of the opening plenary. What is the role of digital rectal exam? So look, I don't know, how did I go?
I actually think it was a very smart move by Silke and Aurelius, because I think DRE has now got a little bit of attention, because there's been a couple of important papers that show us that it's usually not as helpful as we think it is.
Yeah, so we tried to look at it from a few different perspectives. First of all, what about out in primary care, the man just going in for a chat with his GP? And I was really stark when I was reading some recent data to say that big survey in the UK from Prostate Cancer UK said that of 2,000 men, 60-odd% of them have such anxiety about a DRE that they would actively not go to the GP.
So in the primary care setting, not only is it not helpful, but it actively causes harm.
And in particular, this was interesting, Renu, black men, due to more cultural anxieties about it. And Neha Vapiwala is here. Come on over, Neha.
Hello, here
We're
we
already
go.
recording.
Right in the middle here now.
We're talking about a digital rectal exam while we get warmed up for you in the same session.
I am thrilled. That's exactly the topic I was hoping to walk into.
So we were just saying that one of the things we presented in that study was data from the UK showing that men are worried about it. A lot of them, 60-odd%, and actually black men have more concerns about it. It's more of a cultural thing, and they're the men who we most want to get into. So I think the first message was, we shouldn't be, and we showed some papers as well, but we need to, probably take DRE out of the whole primary care conversation altogether. I think. I don't know. What do you think?
I'm so glad you brought this up. Actually, some of the work I'm doing in Philadelphia, where I practice, is specifically looking at myths and misperceptions among the black men in our community. And actually, we also include Latino descent individuals as well, men and women. And in our study, we've basically found that one of the biggest barriers is exactly that fear of the screening, of some of the cultural and other sort of misperceptions that might circulate amongst men with no diagnosis, who understand that it could be life-saving, potentially, depending on what's found, to go to the physician, but just that one barrier alone.
That means they're not even getting a PSA.
That's right. And along with that, they also found, that there was belief that it might be associated with, that prostate cancer is associated with sexually transmitted disease. Other beliefs that sort of, again, could be remedied if you could get the patients in the door. And to the degree that a DRE is keeping them from pursuing that, or the stigma of it is keeping them from pursuing care, it's a shame. It's a shame, because the added value cannot possibly be, worth it, considering what we're
And surely one of the other harms that must cause in the primary care setting is that false reassurance.
Oh, yeah.
That that must also play a role. So for so many reasons, I think in the primary care setting, it's really out.
It's a great point, absolutely. And of all the things the primary care physician needs to be monitoring, that I would think it's just too low yield.
And that was our message, the first message on it, that DRE is pretty much out of the conversation, and we're seeing it drop out of guidelines now. Yes. If you have the average man, asymptomatic, talk about a PSA, forget about the DRE.
Absolutely.
So I think that's a good message.
But there are a couple of other scenarios that you discussed, Declan, in your talk.
I think then, well, what about the guy who's been sent into the urologist because his PSA is up a little bit, there's a family history, whatever about the DRE. What is the role of DRE for us urologists? And that conversation was really all about MRI scanning, wasn't it? The MRI is like a virtual DRE, and we all find it really high value. So I think my message was, yes, absolutely, we should be using MR for all those advantages of, loads of men avoid a biopsy altogether, they can be reassured, etc., etc. However, we also had to face up to the reality that, MRI is not universally available all around the world for urologists who have patients with raised PSA. So therefore, our conclusion on the DRE for that is that it still has a key role as a tool if you don't have an MR available. But the big shout out was we want more. What's it like in the US? Because I did call it out to say even in high income countries like the US, there's a lot of disparity. So the insured patient is getting an MR, maybe the Medicare patients are, but what about younger patients without insurance? There's a lot of disparity for those people.
Absolutely. I'm glad you did bring up that point. We actually had looked at that as well and published data on disparities on the use of MR in patients as part of their their staging workup. And exactly as you said, depending on the insurance coverage, depending on access to or distance from the hospital, we did find that it correlated with zip code and certain racial groups. And again, there is an intersectionality there, right, between certain groups, and if they're employed, unemployed, that often, at least in the U.S., tracks with insurance or not. So in many other wonderful countries where we have, socialized medicine and patients have that access, they don't run that same risk. But in our unemployed population or in our rural populations, it's a major barrier to not have that access.
Yeah. So if you have access to an MRI, definitely trumps a DRE, even in the setting of a urologist's office.
And thank you for putting up with my talk about DRE. But Neha then stood up and did a
It was
really,
a wonderful talk, Declan.
Really
we all enjoyed it. It was fantastic.
As were the graphics.
And Neha chaired that session and gave a fantastic, very comprehensive talk. So comprehensive, in fact, that you had to wish the audience luck.
I did.
In getting through it. But it was amazing. Tell us the main take home.
What was the title of your talk? Because you summarized it very well. It was all about radiation technology.
Right. Well, thank you. Yes, exactly. It was essentially Silke and Aurelius, the organizers, asking me to cover dosing, schedules, fractionation boosts, when to use, when not to use, pelvic nodes, when to use, when not to use, and maybe if I had time, throw in something about PET-positive disease.
All exactly. In 10 minutes before the cowbell goes off, right?
That's right. And I am really quite certain I only had 9. I'm convinced I only had 9 minutes. So some of the takeaways certainly are that, again, more slowly proliferating cancers, such as prostate cancer, as well as late responding tissues, are more sensitive to higher doses per fraction of radiation. And so we need to be mindful as we take advantage of that and leverage that for prostate cancer treatment to deliver escalated dose to the target in shorter, more convenient time frames, that we also be mindful of late effects, because as many people might posit, late effects happen late. And so we need to be thoughtful about, particularly in high-risk prostate cancer, where the target itself may not be limited to the prostate. And as we expand into treating the pelvic nodes and new techniques about including micro boosts and really escalating dose around the urethra and the bowel, that we be very cognizant of the fact that 10 years from now, 15 years from now, we might see some of these toxicities, and just thinking about that now to hopefully save our patients that issue later. But hypofractionation, and certainly moderate hypofractionation, is absolutely standard of care across risk groups. And even for high-risk disease, I do feel comfortable using moderate hypofractionation. In select cases, maybe, if it's a choice between treating this patient or having them not come in for treatment, and this is a major issue in the U.S. as well. We've looked at treatment non-completion rates in our national cancer database, and we found that in particular particular black men had a higher percentage of not completing longer courses of radiation. They would start, but for whatever reason not finish. And so it just stands to reason that if I have the difference between at least delivering a full course, that I might go ahead and offer that SBRT course to an individual who, for many reasons, and again, that's just one group, it's not just black men, it's also men living in rural areas, it's again unemployed, underinsured individuals. So if there's a way that we can make it more accessible, then I'd rather treat the 5 fractions than not at all. But our data there,
fractions only.
yes, but our data there are not as mature in high risk. So I do want to put that caveat out there.
25, no. 5
fractions.
5 fractions.
I'm saying, in select patients.
Okay, yeah.
The standard is 20 to 28 fractions.
These are
anywhere
patients
between 20
where there's
that's
a risk
the
of
moderate.
non-compliance.
That's right.
Right. Okay.
That's right. The moderate hypofrac is definitely much more accepted and mainstream. The ultra hypofrac in high-risk prostate cancer, continued data are needed, including the nodal treatment. All the data are coming, but not yet mature. And we need, as I say, long-term data for those late tissues.
And the other great topic in that session was a talk by Daniel Spratt, talking about the addition of ADT in biochemical recurrence and salvage radiation, and especially the use of AI in that arena. And that was a fantastic talk too.
Yeah, absolutely. Again, we're going to see more and more of its use, the multimodal AI proprietary technology that is essentially taking what we have previously used in terms of our basic clinical and pathologic and to some degree genomic risk factors, and doing what many of us clinicians do in our offices all the time, which is take all of what we know and essentially come up with a gestalt risk in our minds, right? Like, I'm really concerned about distant disease in this person, and here's why. Versus I'm more concerned about local regional disease, and here are the reasons why. Now it's taking that to the next level, right? And validating some of our assumptions and negating some of our others, right? Where we might have thought this person is ostensibly low risk, but here's this validated tool that is now telling me something else. So it's going to be very interesting to see how different countries, different practices adopt some of this technology if they have access to it. And I strongly believe in probably the most important statement, this is how I practice, is if it's not going to change my management, and it means Decipher, the AI tool,
PSMA PET.
all of it, PSMA PET, exactly. If it's not going to change my management, why am I getting it? And do I have a plan for acting on it if it tells me something discordant with every other piece of information? Because we better be prepared before we order those things. Otherwise, it's a disservice to the patient who ends up confused and feeling like, what do I do with this info, right?
Wise words.
Thank you very much, Neha. Great to see you again.
Thank you. Always
the
great to
rest of
see
the
my
meeting.
friends from down under. Thank you so much.
You're welcome. Dr. Jochen Walz, urologist from Marseille, friend of the podcast. Nice to see you here at APCCC.
It's a great pleasure to join you here. It's a great meeting and happy to provide you with some news from APCCC 24.
Seems very multidisciplinary this year. Quite a lot of urologists, way more than I've seen before at the meeting, and a whole bunch of radiation oncologists travel from Australia to come. It's really good.
It's getting like its share now. It used to be like really advanced disease, and now those who do local treatment, radiotherapists, urologists are also getting more and more interested in this and try to be updated and getting into the discussion with your medical oncologist. So it's what we do in our daily practice. So we decide together with our colleagues, our friends from the other specialties, how to treat our patient next Monday, and it makes complete sense that we meet together in these meetings and join the meetings and join forces for all this.
And you're absolutely right, Jochen. And the first session of the meeting was exactly about that, and it was high-risk localized prostate cancer. And you gave a fantastic talk on lymph node dissection. And it always surprises me how, even now, after years of discussing this and debating this, the debate still lives on, doesn't it?
It does, but we're lacking an important element for many years, and that is, I think, the curative effect that you might have. Staging is one thing. I personally think it's important to stage your patient. You will fine-tune, as I said yesterday, we'll fine-tune the management afterwards, which will have an impact on the outcome. But what we definitely would like to see is that you change the cancer control in the long term. And at the EAU this year, Karim Touget was showing the updated data from his randomized trial comparing limited lymph node dissection to extended lymph node dissection, and where the first time you see an effect on metastasis-free survival favoring the extended pelvic lymph node dissection. Yet we don't know what the mechanism behind is. The biochemical recurrence-free survival is not positive. But for me, I think we always say biochemical recurrence-free survival is a weak endpoint. Maybe we should not consider this anymore in this situation. Just look at harder endpoints, and there we have a strong signal. And I think with this new element that we finally see that it makes a difference for the outcome of the patient, the entire discussion, I think, will reactivate it. And I think there will be way more elements now and arguments favoring lymph node dissection than what it had been before, I think.
It's an interesting study, isn't it? Because, when in that trial, when you talk about limited versus extended, you're talking about a difference in median nodes of 2, right? So is it, the talk is that it's location of the mets that makes a difference.
Correct. That's correct. And probably have the same experience in your center. You might do always, you don't do that many lymph node dissections, but if you do it, you might end up having something between 9 lymph nodes and 54.
Yeah.
Even though you're doing exactly the same anatomical field every time. So I'm not sure that the lymph node count is really that reliable and such a good measure or metric to show what kind of lymph node dissection you did. What really counts is the location. So if you cover the anatomical fields and you clean that fields really correctly, it makes a huge difference if you do a limited or an extended one, because you're just taking out the relevant nodes. And that is especially of importance, like the internal iliac areas, where several studies show that this is the area of interest. This is where you have the highest N1 density. This is where you find most of the lymph node metastases.
Declan's eyes are rolling to the back of his head. Declan, what's your view on this?
Look, the lymph node dissection thing, it's I think if anything at the EAU this year, the conversation got even more contentious, didn't it? Because on the one hand, and this was in my plenary at the EAU, you can clearly see there's been a shift in the guidelines this year, very unexpected in my view, that the EAU guidelines seem to have shifted a lot of emphasis away from pelvic lymph node dissection. They've dropped it completely from the intermediate risk thing, no talk about nomograms, and even in the high risk where it used to say do an extended lymph node dissection, and you highlighted this yesterday, it says, well, if you're going to do one, do it extended. So on the one hand, yes, you have this softening, the background being there's no evidence that lymph node dissection improves survival and causes complications. But on the other hand, in the next session at the EAU, as you say, Kareem printed this data, but I think we have to see that paper come out, because here you have a trial, 12 versus 14 nodes. The primary endpoint is negative, there's no difference, but how can anyone explain how that turns out into a difference in distant metastases? So we'll have to see the detail, and I suspect that the interpretation might not be quite as Kareem pitched it. I can't see that, that being a conclusion for a secondary endpoint that wasn't powered for, etc. But we'll see.
So in other words, it's still really one way.
And the other trials that you're very aware of, the trials of lymph node dissection versus no lymph node dissection from Memorial and from Hamburg, from your old centre. I suppose they might tell us something else. It'll probably be still more contentious when those trials read out.
I mean, they are looking at intermediate risk prostate cancer patients, and I'm also in favor in this situation to consider the need of lymph node dissection, and these are probably the area or the patient group.
By the way, that's the cowbell. We will get some footage of the cowbell. We're standing beside the cow here, so that's the end of the coffee break. But yeah, sorry. So for the
intermediate risk prostate cancer patient, probably this is an area where lymph node dissection would not be really necessary.
Yeah.
The incidence of positive nodes is quite low in this situation, so that is something where probably we might get away from it. In high risk, I think it's different. But as you said, indeed, we need to have the full paper coming from Karim to see what the details are, understanding what kind of adjuvant treatments are added and how that was decided and followed up. The one point I would like to stress is there are 1,400 patients in there, and they have more than 150 events of metastases in these patients. So sometimes you have 15 events here, 24 here, and it's just a matter of chance to have it positive or negative, but with 150 events, it's quite a strong statistic. So, but we need to wait for the full.
And to see what happened in between. What happened between them getting recurrence and metastases, the treatment paths, non-specified, etc. But
But I think you're right. In intermediate risk prostate cancer, at least, then we're shifting towards not doing one at least. I mean, a lot of the nomograms are now embedding PSMA PET into it, and the advice for doing node dissections has decreased a lot. But we still have to see about high-risk prostate cancer.
And then, look, you asked a really important question that got a lot of people talking at the end of the day yesterday. So it was in the metastatic hormone-sensitive session, the first session, and all this data was going up about combination therapies for, low-volume, high-volume prostate cancer, recurrent, synchronous, etc., AR pathway inhibitors, which one, chemo, which one, etc., and really world-class speakers delivering it. But you stood up at the end of it and made a point that how are we going to speak to our patients who are in that situation? They've got this diagnosis and we're trying to talk to them about all these various options when we ourselves don't have a clear, I think you described it as a clear vision for this. So yeah, it got a lot of people talking yesterday evening that was a really important point. So do you want to tell us a bit more about your concerns?
The thing is, we had like 7 excellent presentations from the world leaders in the subject, all addressing the point, what kind of treatment should we offer in a certain situation. We have different options, the doublet, triplet, local treatment, MDT and all that. And all of them said, finally, we don't know. We don't have the data to conclude really at the end what kind of treatment should be offered to a patient. And if this situation, very frequently then the patient would be involved in the decision making. And the question is, how can a patient take that decision? If we as physicians, world leaders, are not clear on what might be the right patient for the right treatment, and that is a huge challenge to actually communicate that information and get the patient in a situation where they might decide, or then when we declare going for shared decision making, having a situation where we need to state the patient is unable to take the decision because they're just unable to understand the advantages and disadvantages of each treatment. So it's a challenging situation, and probably we would need to have more involvement from patient representatives to get their priorities, their ideas, and what kind of methodology, if we would like to call it, would be helpful in this situation to get forward to decide.
Great point. I mean, even at a consensus meeting like this, you still thought, well, we probably won't be able to fix that problem because there's a lot of different agents, there's a whole lot of different scenarios that patients end up with their metastatic disease, imaging, blah, 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 and it's very difficult to just have a streamlined solution. But I think it was really important that you brought that topic up because everyone started thinking about it, didn't they?
Yeah, and I mean, you really need to have a very good understanding of what's important to that individual patient. It's very hard to generalize, with the many options, the toxicities related to each option, and what fits in with their lifestyle.
And then probably the most important point we might have for a patient is quality of life. The only issue is that it is so difficult to measure, as Bertrand Tombal was saying. The current questionnaires are not addressing the side effects you might generate and that might help them to have quality of life, one decision-making tool in there. And it's a pity that we don't have this more readily available, because that would be probably something that could help us in this situation where all of them seem to be effective, but where all of them might clearly have an influence on the quality of life, and we would have a clearer vision on it, then probably would be more straightforward to decide.
I think a question like that really puts a lot of things into perspective, because when you hear about one treatment after another, sometimes you just lose vision of what we're trying to do ultimately, which is help our patients.
Thanks very much, Jochen. Great to see you here.
Pleasure.
Enjoy the rest of the meeting.
You too. Thanks.
Tracked down our good friend, Professor Dingwei Ye, urologist and chief of GU Oncology, leader of the urology service at Fudan University Shanghai Cancer Center. Great to see you, old friend.
Very nice to meet you again.
Yeah, and it's really good to see you here at the APCCC meeting in Lugano. This is a global meeting, but it's very important that we have representation from the Asia-Pacific region, because prostate cancer is quite different in the Asian population, and I think it's great to have a lot of representation from this region. So good to have you here.
Yeah, thank you very much to interview with me. And actually, Asia Pacific, especially in China, is the incidence increased very rapidly in the past couple of years. Actually, for instance, in Shanghai, already the third one ranks in the male cancers.
Wow.
Yeah. Okay.
Well, I remember visiting you maybe 8 or 9 years ago, and you were showing me the top 10 cancers.
Yeah.
But prostate was down like 7 or 8, but it's rising up now.
Rising up, especially in the economic developed cities.
Yes.
And Professor, so when these cancer incidences are rising, how are patients presenting? Are they presenting mainly with localized prostate cancer, or are you seeing an increased incidence of metastatic disease on presentation?
Yeah, unfortunately, incidence is increasing, and the mortality is also increasing too.
Yeah.
Actually, it's compare the Asia other countries like Japan and Korea, the 5-year survival is simply low.
Wow.
And the main reason is the early diagnosis is the rate is very low.
Yeah.
Nearly 60% of the initially diagnosed prostate cancer were the locally advanced
Already
or
60%.
even metastasis. So this is the main reason. Yeah.
And tell us a little bit about the management of advanced prostate cancer, because I was there at your next generation imaging preceptorship, so I know you have embraced, next generation imaging PSMA PET. What is the situation like in China, in Shanghai especially?
Especially in Shanghai, actually the PSMA PET-CT, the next generation imaging is more and more commonly used in the big hospital.
Yeah.
But there is big differences between regions.
Yes.
In the Chinese used coastal area is, the economic is relatively speaking developed. So the PSMA PET is commonly used in the big hospitals, but in others, is the regions is not that common. So this is the issue for the future.
And we see it all over all over the world, really, that sort of disparity in what's available. Mm-hmm. And here at this meeting, even during this morning's session, there's still all this discussion. How do we manage the patients? Do we go on the conventional imaging or the PET imaging? So I think those discussions will go for years and years. But good to hear that the NGI is becoming available.
It's interesting, isn't it? Because I think, and Michael Hoffman made this comment actually on Twitter recently, is that a few years ago at APCCC they were deciding whether to do a PSMA PET scan. Now, in many situations, it's assumed that it's already done.
Yeah, and what do we do?
Even Declan, you just last time we met, you mentioned that probably next generation imaging PSMA PET could for the staging before surgery.
Yeah.
Without any lesion by using PSMA PET, it's just not necessary to remove the lipectomy, right? Yeah, it's a good idea in the future's practice.
And I remember going up to you before COVID, and already in China, some people were doing prostatectomy just based on the NGI with no biopsy, and this is still a contentious area, but the imaging is very good.
Yeah.
The other, having heard from you that prostate cancer incidence is increasing and that there's a lot of advanced disease, my question to you is, what is the approach for managing metastatic hormone-sensitive cancer? Is there an increased utilization of combination therapies, ADT plus AR pathway inhibitor or chemo? What's the current situation?
Actually, for the MHSPC patient, according to the Chinese guidelines, or even the international guidelines, we also putting the guideline in the clinical practice. We usually give the AIHI, the abiraterone or other ARI, combine ADD. And for some cases, they would just combine with the docetaxel, like the very high volume burden. And all the Gillessen is very high, and also the metastatic is very, big. Too many, we just combine the docetaxel too.
Yeah, so it's like a triplet.
Yeah, triples. But commonly use the doublet.
And are urologists managing these patients in China, or are medical oncologists involved at the metastatic hormone-sensitive setting? Do you give chemotherapy, or do you just prescribe the AI-targeted therapies? What's the practice like there?
Okay, so very interesting in China, because of the history reasons, mainly the prostate cancer, no matter the stage, early or advanced, they simply see a urologist in the clinic. Then, according to the opinion, the urologist doing the surgery or give the systemic therapy, and even refer to the radiation. Depending on the urologist. It's very interesting.
And I remember you telling me a few years ago that a lot of that was because at the start, when chemotherapy was being used for MHSPC, you couldn't find the oncologist. They're very busy managing other cancers. So if you were going to offer best combination therapies to your patients, the urologist had to learn how to do chemo. And so
that's the very beginning. Even the docetaxel, when they doing the clinical trial.
And you ran
China,
the trial, I remember.
But we try to find some, medical oncology as a co-PI, but no one won't get it. So urologists, try our best to successfully complete the trial and launched in China.
And finally, I suppose with the AR pathway inhibitors now becoming much more available in China, it does make it easier for your urologist to be able to offer these great treatments to our patients.
It's easier for everybody. For the patient, also for the urologist to prescribe.
Now, finally, you and your team at Fudan University Shanghai Cancer Center have been very supportive of GUcast. Your colleague, Professor Yao Zhu, who has come to Melbourne a few times to visit, is now our China editor for GUcast, and so we're very grateful to you and your team for helping our podcast. Do you think podcasting is an enjoyable way of helping educate urologists?
It's a very popular, more and more popular in China, in the urology field, in the GU oncology field in China. I'm very glad and proud to be one of the supporter for this. And it's not only for the how to educate the urologist, and also try to spread out the philosophy how to deal with the growth of prostate cancer in China.
Fantastic.
And our audience in China, do they mainly listen to us, or do they look at the videos as well?
Yeah, they both actually.
Both
actually. They like the cellular phone and still time, just a tea break. All these
in between cases.
Yeah, between cases. It's very enjoyable.
Fantastic.
Thank you.
Thank you so much, and great to see you here participating.
Thank you. The rest of the meeting.
Thank you, Dingwei. Thank you, my friend.
Okay, so Declan, we're at APCCC, and do you remember the competition we ran?
I do.
It was very exciting.
I was kind of jealous I couldn't win that kind of competition myself.
Me too. I wanted to go for it as well, but we offered 3 of our trainees of any GU oncology discipline the opportunity to come to the APCCC in Lugano and, the premier prostate cancer meeting.
What a prize was that?
And it was amazing. So that was, travel, accommodation, registration.
Yeah, all the way from Australia to here in Lugano. 3 awards. We'd lost the competition. We'd about 30 odd videos. You remember you had to submit a video for
just on your smartphone.
Why should I go to this meeting? And what was my GUcast highlight of 2023?
And we heard some amazing stories, but we picked our 3 favorite.
And voila, here they are. Hey! They made it. They made it all the way here.
They made it all the way here. Welcome, guys. It's what's it like to be here?
Shall we just say introduce yourself?
Introduce them, shouldn't we?
Tell us who are you, what do you do, and
Hi, I'm Alice. I'm a Peter Mac Urology unaccredited registrar.
Soon to be trainee, we hope.
That's the dream.
Go, Alice.
Alice, you're here. Great to see you.
Yeah, so Christian Radonk. Peter Mac first trained, and now I'm in Toronto at the moment at Sunnybrook doing a fellowship, which is amazing. So shorter trip to me here.
Yeah, so that's great.
And Sean.
Oh, and hello everyone. I'm Sean. I'm a second-year urology trainee in Sydney at the moment. That's me.
Fantastic.
There they go. So congratulations again to the 3 of you. It was quite a lot of competition. But you rose to the top for various reasons. I can't remember, why did she win? Did she try and speak Italian in her video?
I think she might have tried to learn Italian. We couldn't look past that one.
And you got married recently.
I did, yes. So I'm going to tack on a little honeymoon to the end of this. So thank you.
Matt is here with you as well. So.
Matt is here. He's decided to opt out of the prostate cancer conference, unfortunately, but it's his loss.
Fair enough. And tell me, are you in just day one now, end of day one? Are you enjoying APCCC work coming?
Yeah, we're just talking about how fantastic the education is, and the caliber of knowledge here is just unbelievable.
It really is.
Yeah.
So you'd recommend it to other senior trainees or any ton of trainees around the world?
Absolutely. It's above everything else.
Yeah. And it's very multidisciplinary, Christian. We have a lot of nuclear medicine physicians here among everything else, but big presence of radiation oncologists today because we had high-risk prostate cancer recurrence, etc. So it's been a tour de force from radiation oncology, I think.
Yeah, no, it's been great. So I think, just it's gold, the conference, in terms of lots of talks where maybe there isn't 100% strong data, but there's still some good randomised evidence, and they're just common scenarios that you have in clinic where they are complex discussions and there are multiple different options. I suppose really good discussions, especially in high-risk prostate cancer today, between maybe the non-evidence for surgery or and the strong prospective data for radiation, but there were some knockout punches, I thought. So that was
there you go. He's been listening,
really good, wasn't it?
Sean, back to the surgical side of things. What were some of the reasons you wanted to come to the meeting?
Look, I'm not sure I can look at Christian after those debates in there today. No, but look, it's been fantastic to be here, Renu, and I mentioned on the video that one of the reasons to come here was I just got engaged, which is fantastic.
Congratulations, you just got engaged.
Was that in your video as well, wasn't it? It was in the video, so we have to tell you, it was in the video. Maybe we'll put the edit the video in.
Heartstrings.
He
and,
did, he was going well, and then he said,
very...
and also, what did you say? Basically, you basically said, and also, while I'm there,
it's hard to get time off training, and might pop the question.
Opportunity for a break in training to propose to my girlfriend as well, but don't tell anyone.
Congratulations! There we go.
Anyway, and very smartly, he did it at the start of his trip so that he could just enjoy the rest of the trip, not worry about losing the ring or.
That's right. Now,
congratulations.
APCCC educational content.
And why do you think it's good for a trainee to be in a meeting like this?
Yeah, look, I think as a trainee building up experience, it's hard to be in those complex clinical situations, and I think it's more than the guidelines about how people think. About making those decisions, those little nuances. I think that's what I've definitely got out of today.
Yeah. And Alice, you're going to enter the training program soon, and hopefully, has this sort of kind of fueled your passion for the field?
I think it has. I certainly am already a devotee to surgery, but I think seeing the surgeons up there and discussing sort of their role in the management of prostate cancer is inspiring. I really enjoy it.
I think, Declan, sometimes our trainees get a little bit of a skewed opinion of GU oncology and urology in general. So I think coming to a massively multidisciplinary event like this really showcases some of the complexities of the patients that we deal with.
Yeah, and as we often say, Renu, when people say, "Oh, I want to do a fellowship in like robotic surgery or kidney cancer surgery," the most important thing to plan your future fellowship in is a disease area that you're interested in and that's important for your patient. So that's what this is all about, prostate cancer. So we try and embed that philosophy in our fellowship training program. Say, well, obviously you'll do lots of this type of surgery, that type of surgery, but we want you to be embedded in prostate cancer. What's the best management of prostate cancer? And that means working in this type of environment with these all super talented people from other disciplines as well, and patients here. Lots of great patients at this meeting. So.
And my favorite. Oh, sorry, go on.
You can still come to Radon. We're still open.
You were nearly a urologist at one stage, if I wasn't mistaken.
I did get onto the training program. The same year I got onto Radonc, and so I kept that for a year, and then
I can see years of regret ahead.
Yeah, his eyes are full of regret.
The dark side or the light side, I don't know which one.
It's not the Radoncs that offered you a trip to Lugano.
Boom, boom,
But my favourite story is that your stories have inspired another young resident from another part of the world.
This is a great story, isn't it? So we have listeners all over the world and viewers all over the world, and we have been pushing the meeting a little bit, haven't we, in recent times? Silke and Aurelius have appreciated that, but we've met people here who've said, we listen to your podcast, or we watch the podcast, and that's the reason I came. And come on in, Rory.
Come on in, Rory. He's a tall man. You can have your own microphone.
Thank you for having me.
Rory, just tell us a little bit about yourself.
So I'm a second year urology trainee, currently based in London. And it's definitely thanks to you two that I've heard about the meeting and that I'm here at all. So all good on day one.
Fantastic. And in your training so far, do you think a meeting like this helps?
Just to echo the others, I think the extended panel discussion for those of us definitely in the learning phase, it really helps us understand the nuance behind the limitations of the clinical trials. Similar to the podcast, I will have to go back and listen probably a couple of times to fully understand it, but it really does help.
What a great story.
I love that story. And where are you working? Epsom and St. Helier? Does Steve Gordon work with you?
He does, yeah. And Prof. Parker too.
Very good. So I know Steve Gordon, he's a mate of mine. We trained together. He doesn't do any prostate cancer, disappointingly, but I know he listens to the podcast. So Steve, it's great to have Rory down here learning a bit about prostate cancer, not fiddling around with endourology back at Epsom like he's doing.
We might adopt him at GUcast now.
There we go. So this has been a great success. Are we going to do the same again next year if we can find the funds? Thanks to all our partners.
Yeah, I mean, our partners really made this possible, so it's a huge shout out to them.
And we did have a bunch of people, some of them are here saying, oh, I want to apply for that. Can I apply for that thing? So I don't know, we'll have to do a global fellowship next year.
Yeah, I think so.
So that's it. We're going to have to take them out for a pizza now.
On to drinks.
Yeah, exactly.
Thanks again.
Thank you.
Such a good opportunity. Thank you.
That's it for part 1 of our APCCC highlights. We'll be back in your feed very soon with part 2 of our highlights from this year's meeting. Thanks again to our gold partners at Bayer in China for supporting the conference highlights we love to bring you.